Welcome to the Deep Dive, the show where we cut through the noise, unearth the most important nuggets of knowledge from complex sources, and distill them into insights that truly stick with you.
That's the goal.
Today, we're taking a deep dive into visual problems. We're drawing from a really comprehensive chapter in Lewis's Medical Surgical Nursing.
A foundational text for sure.
And this isn't just about, the mechanics of sight. It's really about a patient's independence, their daily living, their overall quality of life.
Absolutely.
And for us as nurses, it's about our absolutely critical role in prevention, early detection, and, well, effective treatment of vision issues.
What's truly fascinating here, I think, is how interconnected the visual system is with a patient's entire functional ability and well-being. It's not just eyes in isolation.
Right.
Understanding this holistic impact is crucial because it directly informs, well, every aspect of our nursing care, from a basic assessment all the way to intricate patient education.
Absolutely. So to truly grasp the problems, we first need to understand the blueprint, the intricate structures that allow us to see. Think of the eye as this marvel of engineering. It's protected and precisely designed.
Indeed. And the visual system is actually an extension of the central nervous system. It's composed of the eyes, which are incredible light receptors, and then the brain, which has to process and interpret all that visual information.
And it's wonderfully protected, isn't it? The orbit, that robust bony socket. I think it's formed by 7 bones.
7 bones, yeah. It acts like a mini safety helmet for the eyeball.
Right. And it's got crucial openings like the optic canal. That's the protected superhighway for the optic nerve, cranial nerve too, though, sending all that visual info back to the brain.
Exactly. And then you have the 6 extraocular muscles. They work in perfect harmony, like tiny, precise puppeteers, basically, to stabilize and move the eye. Coordination is key.
And beyond that, there are the more obvious protectors.
Yeah, your eyebrows, eyelids, eyelashes, they act as essential physical barriers. And that simple act of blinking, we don't even think about it.
No.
But it distributes tears to keep the eye moist and, importantly, oxygenate the cornea. The lacrimal system handles tear production and drainage, making sure our eyes stay lubricated but don't, overflow.
So those are the protective and external elements. But if we peel back the layers, go into the eyeball itself, what's next?
Okay, inside we find 3 primary layers, each one vital. The outermost layer includes the cornea. That's the transparent avascular front window. It's essential for bending light rays to focus them. Tough, but incredibly sensitive.
Avascular, meaning no blood vessels.
Correct. It gets oxygen from tears and nutrients from the aqueous humor. Then we have the sclera, the white part of the eye. It's a tough fibrous layer that maintains the eye's shape.
Okay, layer 1, what's deeper?
Moving deeper, you hit the uveal tract. This houses the iris that gives your eye its color, and with its central pupil, it controls how much light gets in, like the aperture on a camera. Then there's the ciliary body. It does 2 big things. Produces aqueous humor, we'll come back to that, and it contains muscles that help change the shape of the lens for focusing. And finally, the choroid, a highly vascular layer, providing vital nourishment to the outer retina and other structures.
Got it. Iris, ciliary body, choroid. And at the very heart of vision, what do we find?
That brings us to the internal structures. The aqueous humor, that clear fluid we mentioned, fills the anterior chamber and nourishes those non-vascular structures like the cornea and lens. Its production and reabsorption balance is critical for maintaining intraocular pressure, IOP.
IOP, okay, I hear that term a lot.
You will. It's usually between 10 and 21 millimeters of mercury. An imbalance here, too much pressure, is a key factor in glaucoma.
Okay.
Then the lens itself, it's a biconvex structure sitting right behind the iris. It changes shape, which we call accommodation, to focus light, especially for near objects, like reading.
Right. And behind that?
Behind that is the vitreous humor. It's a transparent, sort of gel-like substance filling the main back cavity of the eye. If you get opacities here, they can block light and affect vision. That's what people mean by floaters.
Ah, okay. Floaters.
And finally, the star of the show, really. The retina, this innermost layer, mostly neurons that can't regenerate, mind you, converts the images into neural signals.
So it's like the film in the camera or the sensor.
Exactly. It contains the macula for your sharp central vision, and right in the center of that, the fovea, which gives us our sharpest visual acuity. Within the retina are rods for peripheral and night vision.
Light and dark only?
Light and dark, yeah. And cones, which are concentrated in fovea, for central and color vision.
Wow. It's an incredibly complex system. Every single part plays such a critical role. Now, here's where it gets really interesting for us as future nurses. How aging impacts this amazing system. What are some of the most significant age-related changes we need to be watching for?
Well, as we age, almost every part of the visual system undergoes some changes. Key ones for nurses definitely include the lens becoming less elastic. That leads to presbyopia, that common difficulty with near vision, needing reading glasses, often starting in the 40s.
Right. Everyone seems to hit that.
Pretty much. More significantly, the lens can develop cataracts. These are opacities, cloudiness that really obscure vision. And retinal changes can lead to age-related macular degeneration, AMD, which hits that crucial central vision.
AMD. Okay.
We also see things like decreased tear production causing dry eyes, which can be really uncomfortable. And the pupil might become smaller and react more slowly to light changes.
So understanding these, let's call them normal age-related changes, is crucial. It brings us right to the next big question. How do we, as nurses, systematically assess the visual system? Let's start with subjective data, what the patient tells us.
Right. A thorough health history is paramount. And don't just ask about eye problems. Remember that many systemic diseases like diabetes, hypertension, and autoimmune conditions like RA can have really profound eye manifestations. Always ask about them.
Good point. Connect the dots.
Exactly. Similarly, a complete medication list is vital. For example, long-term corticosteroid use can contribute to glaucoma or cataracts. And certain drugs, like hydroxychloroquine for autoimmune diseases, need annual eye exams because of the risk of retinal toxicity.
Wow, okay. Need to know those med side effects.
Definitely. And when we think about functional health patterns, the impact of vision loss is just profound. Consider FM, that 81-year-old woman we mentioned. She comes into the ED saying her vision looks like everything is covered with a spider web. She sees periodic light flashes and small white spots floating.
Okay.
Now, she had cataract surgery 2 months ago, has diabetes and hypertension, takes metoprolol. What's going through your mind hearing that history and those symptoms?
Spider web, flashes of light. That sounds alarming, especially with recent surgery and diabetes.
Huge red flags. FM's symptoms, particularly the spider web and flashes, immediately make me think of an acute, serious problem. Given her age, the recent surgery, the systemic additions, my first thought is a retinal detachment.
Okay.
So I'd quickly ask about the onset. When did this start? Is there any pain? Any change in her central or peripheral vision? Any recent falls or bumps to the head?
Excellent. Get the specifics quickly. Now, let's move to objective data, what we can actually see and measure. When assessing FM, or really any patient, what are the core objective assessments for the visual system?
We always start with visual acuity. Measure it for each eye separately. The Snellen chart is for distance. Vision patient stands 20 feet away. That gives us that familiar 20/20 reading.
And 20/40 means?
It means the patient sees at 20 feet what a person with normal 20/20 vision sees clearly at 40 feet. So, worse than normal. For near vision, we use a Jaeger chart held about 14 inches away.
Okay. Acuity first. Then
we check extraocular muscle functions. We look at the corneal light reflex shining a light to see if the reflection is symmetric on both corneas. And we observe the patient's eye movements to the 6 cardinal positions of gaze. That helps spot any muscle weakness or nerve issues, checking cranial nerves 3rd, 4, and 6.
making them follow your finger in that H pattern.
Exactly that pattern. We're watching for smooth, coordinated movement.
And pupils and pressure. You mentioned those earlier.
Right. We use PER-OA, that stands for pupils equal, round, reactive to light, and accommodation to check pupil function. How they constrict with light, both directly and consensually.
Meaning the other pupil constricts too.
Yes. And how they constrict and converge when focusing from far to near. Then, IOP measurement via tonometry. Super important. Normal range, 10-21 millimeter Hg. Elevated pressure is that critical indicator for glaucoma. We'll discuss more.
Okay. And looking inside?
Finally, yes, using an ophthalmoscope, we inspect internal structures like the retina and optic nerve. We're looking for things like hemorrhages, exudates, those little spots you see with diabetes or hypertension, or changes in the optic disc, which can reveal conditions like diabetic retinopathy or glaucoma. And in FM's case, this is where we look for signs of a detached retina.
Which they found. Her objective findings included PRL and intact eye movements, but that ophthalmoscopic exam revealed a partial retinal detachment, later confirmed by ultrasound. This leads us nicely to diagnostic studies. What are some other key tests nurses should be aware of?
Well, the Amsler grid test is a really simple self-test patients can do at home. They look at a grid, and if lines appear wavy or are missing, it can signal macular problems like we see in AMD.
Easy screening tool.
Very useful. Then there's fluorescein angiography. It assesses retinal blood flow using an IV dye. As nurses, we must tell patients they might feel a bit nauseous transiently, and their skin and urine might turn a temporary yellow-orange color. Don't let that alarm them.
Good heads up.
And ultrasonography is great when you can't see the back of the eye clearly, maybe due to cataracts or bleeding. It helps diagnose foreign bodies, tumors, or, as with FM, retinal detachments.
Okay, so we've laid the groundwork. Anatomy, assessment, diagnostics. Now, let's shift focus to some of the most common vision problems we encounter and, crucially, how we manage them in nursing practice. Let's start with refractive errors. Seems like the most common issue.
It is. Refractive errors happen when the eye doesn't bend or refract light properly to focus it right on the retina. You've got myopia or nearsightedness, where distant objects are blurry. That's the most common one.
Can't see the board in class?
Exactly. Then hyperopia or farsightedness, where near objects are blurry. Presbyopia, that age-related near vision difficulty we talked about. And astigmatism, which causes distorted vision because the cornea has an uneven curve, kind of like a football shape instead of a basketball.
So glasses or contacts usually fix these.
For the most part, yes. Corrective lenses work well. But speaking of contacts, as nurses, we must stress to wearers the serious risk of microbial keratitis. That's a nasty corneal infection if their hygiene is poor.
So proper cleaning is non-negotiable.
Absolutely non-negotiable. Hand washing, proper solution use, not overwearing them, and immediately reporting any redness, pain, or vision changes are just paramount. It can cause blindness if not treated.
That's a critical teaching point. Now let's talk about conditions that can lead to visual impairment, something that isn't fully correctable with lenses or surgery. We define legal blindness as best corrected vision of 2200 or less, right?
Or a visual field of 20 degrees or less. And sadly, most blindness in the U.S. is caused by common eye diseases. Cataracts, glaucoma, AMD, and diabetic retinopathy. Things we can often manage or slow down if caught early.
So what's our nursing role when someone has significant visual impairment?
Our nursing management is really about holistic support. We need to assess the impact on their daily tasks: reading, cooking, mobility. How are they coping emotionally? What support systems do they have? In acute care, like in the hospital, providing emotional support is huge. And for safety, we use the sighted guide technique.
Remind us how that works.
You offer the patient your elbow, walk slightly ahead and to the side at a comfortable pace. Describe the environment. We're approaching a doorway. There are 3 steps down here. Give advance notice of obstacles. Help them find a chair by placing their hand on the back of it.
Simple techniques, but make a huge difference.
Huge difference. In ambulatory care, we connect patients with resources, state agencies, support groups. We discuss vision substitution like Braille or audiobooks, or vision enhancement techniques like magnifiers or better lighting. And we always remember those gerontologic considerations. Older adults often face compounded challenges. Maybe other health issues, mobility problems, increased fall risk, difficulty managing eye drops, plus the emotional toll of losing independence.
It's a lot to manage. Now, switching gears to something often preventable, but always an emergency, eye trauma.
Yeah, eye trauma demands immediate, correct action. And chemical burns are particularly devastating. Especially alkaline chemicals like drain cleaner or ammonia, they penetrate deeper and cause more damage than acids.
So what's the absolute first thing to do?
Immediate and continuous irrigation. Flush the eye with sterile saline or even tap water right away for at least 15-20 minutes, maybe longer. Getting that chemical out is the priority.
Don't wait, just flush.
Just flush. Our other initial interventions include assessing visual acuity if possible, but never put pressure on the injured eye.
Yeah.
If there's a foreign object sticking out, stabilize it, don't pull it out. Cover the eye with a dry sterile patch and a protective shield like a paper cup taped over it. Keep the patient NPO because they might need surgery. Elevate the head of the bed and give pain meds. And our role in prevention. Huge. Educating people about wearing protective eyewear for sports, yard work, handling chemicals, it's vital.
Absolutely. Okay, next up, let's explore cataracts, that opacity within the lens. You said it's one of the most common eye surgeries.
It is very common, especially in older adults. Most cataracts are age-related, or senile cataracts. But other risk factors include trauma, smoking, heavy alcohol use, radiation or UV light exposure, certain drugs like steroids, and definitely diabetes, which can cause them to develop earlier.
And what does it do to vision?
It clouds the lens, leading to a gradual decrease in visual acuity. People often notice abnormal color perception, things look faded or yellowish. And glare becomes a big problem, often worse at night when the pupil dilates and lets more scattered light in.
How are they diagnosed and treated?
Diagnosis is usually straightforward, assessing visual acuity, and the doctor can see the opacity with an ophthalmoscope or slit lamp. For interprofessional care, early on, non-surgical things help. Updating glasses, using magnifiers, increasing lighting, maybe avoiding night driving. Surgery, usually phacoemulsification.
Emulsification.
Yeah, phaco. It's where they use ultrasound to break up the cloudy lens into tiny fragments, then suction them out through a very small incision. It's usually sutureless. Surgery is considered when the cataract significantly impacts the patient's quality of life or ability to function.
And pre-op and post-op.
Pre-op, patients get several types of eye drops. Mydriatics to dilate the pupil, cycloplegics to paralyze focusing muscles temporarily, and NSAIDs to reduce inflammation. There's a drug alert here. Teach patients to wear dark glasses after getting dilating drops because they'll be very sensitive to light, photophobic, and monitor for systemic side effects like tachycardia. Post-op, strict activity restrictions are crucial, avoiding bending, stooping, coughing hard, or lifting heavy things, anything that increases IOP.
So what are the key nursing takeaways for managing a patient having cataract surgery? What do we really need to focus on?
Our nursing management is huge on education and support. Pre-op, provide clear info, answer questions, reduce anxiety. Post-op, pain is usually mild, controlled with mild analgesics like acetaminophen. But, and this is important, intense pain must be reported immediately. It could signal a complication like hemorrhage, infection, or a sudden rise in IOP.
Okay, severe pain equals emergency.
Definitely.
Okay.
We teach proper hygiene, how to instill eye drops correctly, the signs of infection to watch for like increased redness, discharge, or worsening vision, reinforce those activity restrictions, and help them cope with temporary vision changes, like maybe using large print materials or audiobooks for a bit. For older patients, we really need to assess their ability to manage the eye drops. Dexterity can be an issue, maybe involve a family member.
Good points.
Yeah.
And speaking of emergencies, let's circle back to retinal detachment, like FM experienced. You said it's a true emergency, a separation of the retina, untreated, blindness.
Untreated, yes, it can lead to permanent vision loss or blindness in the affected eye. It's often caused by a retinal break, a tear, or a hole. This commonly happens when the vitreous humor, that gel inside the eye, shrinks with age and pulls on the retina. Liquid vitreous can then seep through the break and get behind the retina, lifting it off.
Like wallpaper peeling off a wall.
That's a good analogy.
Mhm.
Risk factors include age, severe myopia, nearsightedness, previous eye surgery or trauma, and conditions like diabetic retinopathy.
And the symptoms, FM had flashes and floaters.
Those are classic initial symptoms. Patients often describe flashes of light, photoxia, sudden onset or increase in floaters. Those little specks may be described as a cobweb, hairnet, or a ring in their vision. As the detachment progresses, they might notice a shadow or a curtain coming across the field of vision. Importantly, there is usually no pain. FM spiderweb and flashes fit this perfectly.
And treatment is surgical.
Yes, surgical intervention is needed to reattach the retina. Options include things like laser photocoagulation or cryopexy to seal the breaks, scleral buckling, where a band is placed around the eye to push the wall towards the retina, or intraocular procedures like pneumatic retinopexy, injecting a gas bubble.
A gas bubble.
Yes, a temporary gas bubble is injected into the vitreous cavity. It floats up and presses the retina back into place. This requires the patient to maintain specific head positioning for days or even weeks afterwards, which can be really challenging. Or a vitrectomy, removing the vitreous, might be done, especially if there's scar tissue pulling on the retina.
So post-op care sounds intense, especially with positioning.
It can be. Nursing management is vital. Providing emotional support during this urgent situation is key. Discharge teaching is crucial. How to take multiple eye drops, adhering to activity restrictions, managing pain, and importantly, educating the patient on signs and symptoms of retinal detachment in the other eye, because they're at higher risk. And always emphasize protective eyewear for prevention.
Okay. Moving on to another major one, age-related macular degeneration, AMD. You said it's the leading cause of irreversible central vision loss.
Yes, particularly in older adults. It affects the macula, that central part of the retina responsible for sharp, detailed vision needed for reading, driving, recognizing faces.
And there are two types.
Two types, dry AMD and wet AMD. Dry AMD is much more common, about 90% of cases. It's a slower, progressive, painless vision loss as the macular cells atrophy, and these yellowish deposits called drusen accumulate under the retina. Close vision tasks become increasingly difficult.
Okay, dry is slow, drusen. What about wet?
Wet AMD is less common but more severe. It involves the growth of abnormal, fragile blood vessels in or near the macula. These vessels leak fluid and blood, leading to scar tissue formation and a more rapid, significant loss of central vision. Many people with wet AMD had dry AMD first.
What causes it, and who's at risk?
It's related to retinal aging. Genetics play a role. Risk factors include family history, UV light exposure, hyperopia, and especially smoking. There's a strong dose-response relationship with smoking.
Smoking again.
Always. Clinically, patients experience blurred or darkened central vision. They might notice scotomas, which are blind spots in their central vision, and metamorphopsia, that's vision distortion, where straight lines appear wavy or objects look smaller or larger than they are.
How do they test for that wavy lines thing?
That's the Amsler grid test we mentioned earlier. Patients look at the grid daily and report any changes like wavy lines, distortion, or missing areas. It's a key tool for monitoring. Ophthalmoscopy shows the drusen in dry AMD or leakage in wet AMD.
And treatment. Can you reverse it?
Unfortunately, there's no cure, especially for dry AMD. The goal is to slow progression and maximize remaining vision. For wet AMD, the main treatments are intravitreal injections of anti-VEGF medication.
Injections into the eye.
Directly into the vitreous cavity, yes. Drugs like ranibizumab or bevacizumab inhibit the growth of those abnormal blood vessels. They can slow vision loss and sometimes improve vision, but require repeated injections, often every 4-6 weeks.
Wow, that takes commitment.
It does. Another option for some types of wet AMD is photodynamic therapy, PDT. A drug called verteporfin is given IV, then activated by a laser light in the eye to clot off the abnormal vessels. A crucial nursing teaching point for PDT. The patient becomes photosensitive and must avoid direct sunlight and other intense light for 5 days after treatment to prevent severe skin burns.
Okay, very important warning.
For general management, nutritional supplements containing antioxidant vitamins C and E, lutein, zeaxanthin, and zinc, like the ARD's formulation, are often recommended, especially for intermediate dry AMD. And of course, smoking cessation is critical. Nursing management focuses on helping patients adapt, using low vision aids, and providing emotional support for this chronic, often frustrating condition.
Okay, finally, we absolutely must discuss glaucoma, the silent thief of sight. You highlighted this earlier, second leading cause of permanent blindness overall, #1 among Black populations. And many people don't even know they have it.
That's the tragedy of glaucoma, especially the most common type. It often progresses silently until significant irreversible vision loss has occurred. It's basically a group of disorders characterized by increased intraocular pressure, IOP, optic nerve atrophy, and peripheral visual field loss.
What causes that increased IOP?
It's an imbalance between the production of aqueous humor, inflow, and its reabsorption or drainage, outflow. Think of it like a sink. If the faucet is on too high or the drain is clogged, the pressure builds up. In glaucoma, this sustained increased pressure damages the delicate optic nerve fibers.
Makes sense. What are the main types?
Primary open-angle glaucoma, POAG, is the most common type, about 90%. Here, the drainage channels the trabecular meshwork in the angle where the iris meets the cornea become clogged over time. Outflow decreases, IOP gradually rises. It develops slowly, usually without pain. The first symptom is often subtle loss of peripheral vision, which people may not notice until it's quite advanced, leading to tunnel vision.
Silent indeed. What's the other main type?
Angle closure glaucoma, ACG. Here, the angle itself becomes narrow or closed, physically blocking the outflow of aqueous humor. This can happen suddenly, often triggered by pupil dilation in people with anatomically narrow angles, maybe from certain medications, being in the dark, or even emotional excitement. Acute angle closure glaucoma, AACG, is a true ocular emergency.
Emergency. How does that present?
It's dramatic. Sudden, severe pain in or around the eye, nausea and vomiting. Seeing colored halos or rainbows around lights, blurred vision, maybe a red eye, the IOP can shoot up very high, very quickly. Immediate treatment is needed to prevent blindness.
Okay, ACG is sudden and painful. POAG is slow and silent. How do we diagnose them?
Key diagnostic studies include IOP measurement. In POA, it's usually elevated, maybe 22-32 millimeter Hg, but can sometimes be normal. In ACG, it can be over 50 millimeter Hg. Slit lamp microscopy lets the doctor examine the angle to open in POAG, narrow or closed in ACG. Perimetry testing maps the visual field to detect that peripheral loss, even subtle early changes. And ophthalmoscopy is critical to look at the optic disc. In chronic POAG, we see optic disc cupping. The optic nerve head looks wider, deeper, paler, sort of scooped out. That's a hallmark of nerve damage. Cupping. Got it. So how is it treated, especially chronic POA? The primary goal for all glaucoma is to lower the IOP to prevent further optic nerve damage. For chronic open-angle glaucoma, drug therapy with eye drops is usually the first line. Prostaglandin analogs are often preferred now. They increase outflow. Beta blockers are also common, but there are nursing considerations. Beta blockers like timolol can have systemic effects. They're contraindicated in patients with bradycardia, heart block, heart failure, and the non-cardioselective ones are also contraindicated in COPD or asthma because they can cause bronchospasm.
Need to check that history carefully before starting those drops.
Absolutely. Other drops work by decreasing aqueous production or increasing outflow. If drops aren't enough, laser therapy, argon laser trabeculoplasty, ALT, can help open the drainage channels. Or filtration surgery like a trabeculectomy might be needed to create a new drainage pathway.
And for the acute angle closure emergency.
For acute angle closure glaucoma, it's immediate treatment to lower the IOP drastically. This involves oral or IV medications like carbonic anhydrase inhibitors or hyperosmotic agents like mannitol. Once the pressure is controlled, a laser peripheral iridotomy is usually done, creating a small hole in the iris to allow aqueous fluid to flow, preventing future attacks.
So nursing management for glaucoma seems focused on long-term adherence and education.
Hugely important. It's a chronic condition requiring lifelong management. Our assessment includes the patient's ability to understand and adhere to the complex eye drop regimen, their psychological reaction to a potentially blinding diagnosis, and involving caregivers if needed. Planning focuses on preventing further vision loss, ensuring adherence, maintaining safe function, and relieving pain if present.
And implementation.
Health promotion is key. Stress the importance of regular comprehensive eye exams for early detection, especially for high-risk individuals like older adults, African Americans, people with family history. Educate on the purpose, frequency, and correct technique for instilling eye drops, getting them in the eye, not running down the cheek, waiting between different drops. Encourage adherence. Help find ways to manage side effects, maybe set reminders. It's a partnership.
Lifelong partnership. Are there other serious eye conditions we should briefly mention?
Yes, things like intraocular inflammation and infection uveitis, or endophthalmitis, which is a devastating infection inside the eye, often after surgery or injury, potentially leading to blindness very quickly. Also, ocular tumors, like uveal melanoma, which is rare but serious. And sadly, sometimes enucleation, the surgical removal of the eye, becomes necessary usually for a blind, painful eye that can't be salvaged, or due to cancer or severe trauma.
That must be incredibly difficult for the patient.
It's a profound loss. Our role includes providing really strong emotional support through the grieving process, anticipating their needs, along with practical teaching on postoperative care, wound cleansing, and eventually managing the ocular prosthesis, how to remove it, clean it, insert it.
And that brings us toward the end of our deep dive into visual problems. Wow. We've covered a tremendous amount of ground, haven't we? From the intricate anatomy right through to critical nursing interventions for conditions like FM's retinal detachment.
We really covered the spectrum.
So, to recap the main clinical takeaways for our nursing students listening. First, appreciate the complex yet elegant structures of the visual system. Second, remember the indispensable role of thorough nursing assessment using both subjective clues, what the patient tells you, and objective findings, what you measure and see to identify issues early.
That assessment piece is fundamental.
Third, understand the wide spectrum of conditions, from common refractive errors and infections, right up to urgent emergencies like retinal detachment, acute glaucoma, and chemical burns. Fourth, recognize the profound impact visual impairment has on a patient's life and the crucial importance of patient education for prevention, for medication adherence, for adapting to vision changes.
Education empowers the patient.
And finally, never underestimate the power of early detection and timely intervention in preserving a patient's most precious sense sight.
Absolutely. And this, I think, raises an important question for you, our future nurses, to reflect on. How will you not only apply your clinical knowledge to treat the physical eye, but also holistically support and empower your patients? How will you help them maintain their independence and quality of life, even when facing altered sensory perception?
That's a powerful thought to carry forward into practice. We really hope this deep dive has given you a clearer vision, no pun intended, of visual problems and your absolutely crucial role in eye health. Until next time, keep learning, keep growing, and keep making a difference.